Hi everyone, my name is Zeyu Guan. I'm one of the final year medical students from Barts and London. So today I'll be talking through gastroenterology, the first part, and the topics I'll be covering is GI bleeding, focusing mainly on the management in acute settings. As well as that, I'll be covering things like peptic ulcer disease, its presentation and management, and then I'll go on to talk a little bit about GORD, or gastroesophageal reflux disease, and then I'll be going through the drugs of the GI tract. Some of my colleagues will also cover things like inflammatory bowel disease and things like malignancies. Therefore, I won't go into too much details in terms of the specifics about GI bleeding. Okay, so disclaimer, the slides is made up a combination of the GI bleed lecture that you have on QM+. Therefore, some of it might be very familiar or very similar to that, as well as that some of the lectures is also taken from the previous PAL lectures, and as well as the past med knowledge tutor. So, GI bleeding. Why is it important? It is the most common GI emergency with the incidence of around 50 to 150 per 100,000. It's very common in poorer areas, and unfortunately it's got 11 to 13% mortality, especially if they have comorbidities and if they're elderly and if they're on any sort of anticoagulants. So these things is very important to establish, especially if you're taking a history. So in terms of etiology wise, there's a lot of things that can cause GI bleeding, right from the upper GI tract to the lower GI tract. So here's just a non-exhaustive list of all the causes. In this lecture, we'll be going in some detail about the ulceration or peptic ulcer disease. I won't be going into much detail for any other things, such as portal hypertension, tumor, diverticular disease, ischemic bowel, also IBD, etc., etc. These will be covered in some of the lectures that follows this one. Okay. So, how do they present? Okay, so the presentation is variable. Obviously, you can have bleeds from any part of the GI tract. So, if you've got an upper GI bleed, still 10% present with, PR bleeding, as well as if you have lower GI tract bleeding, only 10% presents, 10% presents with melena. As well as this, 5% of GI bleeding is also from small bowel, which sometimes is very difficult to distinguish. And obviously, the main thing is to figure out exactly how much and how fast the patient is actually losing blood. So here's a brief case just to start us off. So you got a 54-year-old female who presents with a several episodes of melena over the past 3 days. Okay, her blood pressure is 86/55 with heart rate of 110. So what will be the first thing you would consider to do? The thing you would do first is definitely get IV access, as well as put in some fluids and consider blood transfusions. Okay. So hemodynamics, there are a few different classes of loss. It's quite important for this to learn this, especially for exam purposes. So you've got class 1, which is around 10 to 15% loss. In terms of physical signs, you don't really get any, and there's not really much of a physical compensation. Okay, so in terms of class 2, that's when you've got 15 to 30% loss. You would then show signs of postural hypertension, as well as generalized vasoconstriction. So you might see some sort of peripheral shutdown starting from class 2. As well as this, in class 3, that's when you've lost a lot of blood, 30 to 40% loss, then you would get things like hypotension, tachycardia over with heart rate of over 120. And then you've got class 4, where you lost more than 40% of your blood. And how would you resuscitate? You would consider using a wide bore or a grey cannula. So here is a list of what you get. You definitely want to put in at least a grey, where you can give 150 ml per minute of fluid or blood, but obviously the quicker the better in this kind of resuscitation situation. So you might want to also consider orange. So, like I said, you want to get a good IV access, so at least grey. If not, if you have problems, then you can consider green cannulas too. So obviously they will get hypotensive if they've lost at least 2 liters. Therefore, you want to replace 2 liters ASAP. Obviously, the first thing you would consider in any condition is to consider an ATU assessment. In this case, you want to, the patient is breathing, talking fine. However, when you get to circulation, it's obvious that the patient is volume depleted, and therefore they need to be replenished very quickly. And that's the main message here. So if they are bleeding, or if you know they're bleeding and you want to cross-match them and start the blood transfusion immediately before you send them to any kind of endoscopy or any further management. So this picture is just demonstrating the blood supply, and that the gut is very well supplied blood. Therefore, you can lose easily 20 to 40% of the blood volume. So, history-wise, you want to, like any history, you want to be systematic, and obviously you want to find out whether this is a chronic thing or acute exacerbation of, say, inflammatory bowel disease, etc. As well as that, if they present with any kind of pain, you want to go through Socrates, because that will give you an idea of what the etiology of the blood could be. It could be related to the liver or varices. It could be upper GI bleeds due to peptic ulcer, due to drug use or such as NSAIDs. As well as this, obviously you want to rule out any infective cause. Therefore, you want to ask them the onset and whether they've had any recent traveling. As well as this, you definitely want to rule out any sort of malignancy, where they would, alongside inflammatory bowel disease, they would show red flag signs such as fever, night sweat, and weight loss. And then, like I said, GI bleed can be easily caused by things like anticoagulants as well as NSAIDs use. And another cause of GI bleed can also be things like radiotherapy. And if they've got a history of AF and you see this in the exam, the answer will always be ischemic bowel disease, always. And then you also want to obviously inquire about family history malignancies. And then social history wise, obviously mostly to do with liver conditions, alcohol, illicit drug use, as hepatitis or liver pathologies can lead to things like portal hypertension, and then leads to varices. And then smoking history is important for UC and Crohn's. And obviously, don't forget ICE, so idea, consent, expectation of the patient, which is always very useful and gains you tremendous amount of marks in OSCEs. If purely based on those, you'll probably pass. So anyways, examination wise, you would consider doing your full abdo examination I won't go into too much detail, so don't forget to observe for any signs in the fingers, especially clubbing for inflammatory bowel disease, as well as look for any obvious signs of spider nevi or any other ascites, etc., for signs of portal hypertension. And at the end, do not forget to offer PR, which is very important in almost all the GI conditions to do a PR examination. And then you would consider doing basic OBS, so your O2 saturation, heart rate, respiratory rate, blood pressure, etc., etc. This is again following on from your ATE assessment. You need to constantly make sure that the patient is stable, and obviously in terms of blood tests, you want to do a full blood count to look for any chronicity, or like if it's chronic, then they would show a low HB or even acute setting if they've lost enough, obviously. And use any LFTs, and then want to do a coagulation screen to make sure they don't have an active bleeding problem. This will definitely alter your management plan. As well as this, you want to do a groups and save and cross-match some blood, just in case the patient needs to replenish any blood loss the patient's already had to stabilize them. Okay, so in terms of risk stratification of whether the patient need to go straight to endoscopy or undergoes purely medical management, the main thing we would look at is something called a Rockwell score, which I'll go into a bit further. So here's just some facts, so that 80% of ulcers basically stops spontaneously, and only 60% of varices stop spontaneously. Therefore, you don't need to do an OGD or some form of treatment in all cases. Therefore, we need a strategy, and the strategy we use, or a lot of people use, is the Rockwell score. So, what is the Rockwell score? So there's a few categories that is considered, mainly factors including the age, whether they have some form of shock, etc., or any kind of comorbidities, congestive cardiac failure, or ischemic heart disease, for example, as well as any other forms of organ failure or cancer, etc. And if you know that they have malarialized tear, then definitely there's a lower score, as well as if you think that the patient has upper GI tract cancer, then obviously that would score more. Another thing that I didn't get when I was doing this module is the major stigmata of recent bleeding. So this, they like to ask in exams, and they would be like, which of these factors is considered in the Rockwell score? So they might put in like clots or vessels or active bleeding as one of the options. So you want to choose that. As well as that, they might put in some other things. But just remember, clots, vessels, and active bleeding is within the Rockwell score in the major stigmata of recent bleeding section. Okay, so here's a picture or screenshot I directly taken from your lectures. So as you can see here, you've got the different factors or the risk of rebleeding and the stigmatas you would see in an endoscopy. So if it's active bleeding, obviously if you see active bleeding, there's the risk, you can see that it's very high. And then this is MBBV, is new blood vessel, as well as clots and dots, and then you've got clean base. Obviously that's the best prognosis with least risk of rebleeding. And then here again, there's another graph I took from your lectures, is just to show that the higher the Rockwell score, the higher chance of rebleeding as well as mortality. So if they've had a high Rockwell score and they've rebled, there's a higher mortality compared to, obviously they didn't rebleed, but they still have a high mortality rate. They've got a higher Rockwell score. So yes, of course, if the blood comes back and it shows that the patient got less than 550 platelet, as well as INR of more than 1.5, then you would want to try and reverse the cause or stop any antiplatelet drugs or anticoagulant drugs such as clopidogrel or aspirin. As well as that, you want to start the patient on a PPI, ideally a 30 milligram of lansoprazole. You can also consider PPI infusion, but always get some sort of senior opinion on that. And you would definitely consider tranexamic acid if they got a higher than expected INR, or if you suspect they are actively bleeding. And then if they are on warfarin, you need to consider giving vitamin K, human prothrombin complex, free frozen plasma, as well as you need to speak to a hematologist. So the exact kind of treatment pathway of warfarin reversal, you can find it on any BNF, and you need to be familiar with that, especially for the PSA, because they like to ask patients who are on warfarin how to reverse. So in terms of going for endoscopy, you want to, like I said many times, you need to stabilize the patient first, and then you want to call an endoscopist ASAP, whether it's day or night. You want to do it the same day or same morning. So in terms of how you would call them, obviously you would go through your SBAR handover, so situational background assessment, and then recommendations. So here's just an example. I won't read it out, but the main thing is that you want to present the key facts. You want to have like a highlighter. The patient is hemodynamically unstable, you want to state that, and you want to basically be a good salesman and let them know why this patient needs to have the endoscopy first, rather than the 10,000 other patients that they may also have on their list. Okay, so in terms of other management, for a varicose bleed or any other bleed, you want to consider prophylactic antibiotics such as cephalosporins, quinolones, and augmentins. So studies have shown that there's 25% reduction in mortality in patient who's on antibiotics, as well as 2 to 3 times less likely to rebleed. As well as that, sepsis. This is because that sepsis increases chance of getting portal hypertension. This is also the case in dental practices, where you can get bacteremia in around 10 to 50% of patients. So in terms of varicose, if you suspect that this is a varicose bleed, then you would start the patient on a terlipressin 1 to 2 milligrams QDS, and you want to start that straight away if you suspect it. As well as that, you would also start the patient on a creoltide, which is a somatostatin analog. It is often given as an infusion, especially for the management for the esophageal varices in patient who has liver cirrhosis. This is so that they have a reduced portal hypertension, although the exact mechanism and the exact effect is still being actually trialed, and this could all change basically. And in terms of other things you want to consider, you obviously want to treat any active bleeding to prevent bleeding. As well as that, you need to make sure that before the procedure, like I said, make sure that the patient has cross-matched blood, and as well as that, you need to make sure they're stable, with a stable blood pressure and a HB of more than 7. And you want to consider GA, of course, if the patient is very agitated, if you think that they is highly unlikely to tolerate the endoscopy well, as well as that if they have a low GCS, or that you need to protect their airways. A few things you can do with endoscopy. So you can consider a sclerotherapy, where you would use a needle to inject sclerosant into the varix. In approximately 70% of the cases, the the blood bleeding will stop. However, there is a rebleed of 45%. There's also another thing you can do is banding, where more than 80% of the cases the bleeding will stop. However, there's a 27% of rebleeding chance. And then there's the sense taking tube, where it's only really performed by experienced staff, however, it's 90% effective. And then you can also consider stents. Studies have shown it again to be very effective. So after endoscopy, you can consider using a PPI. The main rationale behind this is that if it's acidic or low pH, this activates pepsin, which will break down the clot as well as inactivate platelets. Therefore, the patient's more likely to start bleeding again. And you would consider using infusion, 80 milligrams bolus. In terms of surgery-wise, you can involve the surgical team with all major cases, and that includes around 10% of the bleeding peptic ulcers, and the indications of that including uncontrolled bleeding or further hemorrhage, as well as if they have more than 2 failed endoscopic treatments. As well as that, you would also consider it if they are older patients who tolerate hypovolemia very poorly. Therefore, you would consider doing a surgery quite early. In terms of follow-up wise, after the first one, the second endoscopy, you want to do another one at 24 hours to 48 hours if the patient is stable. However, if they are on PPI infusion already, then you probably wouldn't want to carry out endoscopy. And then you want to make sure to treat the cause of the peptic ulcer. So you want to make sure that you eradicate the H. pylori if they have it, if they're positive for that, and make sure that they don't take any forms of NSAIDs. And then the eradication of H. pylori must be confirmed by the GP, as 65 to 95% chance that there will be a recurrence of ulcers in patients who don't have their H. pylori eradicated. So how would you restart? When would you restart antiplatelet therapy? Obviously, if they do start aspirin, you want to maintain that with a PPI. For example, 30 milligrams of lansoprazole. And it's shown that in a study that only 1 to 3% had rebleed compared to 10 to 15% who were on placebo, who didn't have a PPI, obviously. And then you want to do a re-look with the OGD for any form of gastric ulcer, maybe if they still have symptoms or if they show active bleed again. Okay. So other treatment includes beta blockers, especially for varices, and it's shown that it can decrease the rebleed by 40%. As well as this, you can also consider doing some sort of rebanding for varices. And here's just some more statistics that you can read over yourself. And then you can also consider the TIPS procedure, or transjugular intrahepatic portosystemic shunt, which again will require some specialist opinions. And the ultimate treatment for liver cirrhosis or varices is obviously for a liver transplant, and 60 to 80% has a 5-year survival rate. However, without it, there's a 25% mortality at year 1. Okay, now we're going to peptic ulcer disease. It is caused by action of the peptic juices, or the acid produced by the gut on the gastrointestinal mucosa. So the common sites of this can be in the stomach, it can be in mucus diverticulum, it can be in the esophagus, or it can be in the duodenum. Okay, so risk factors including H. pylori, obviously, if they have that, as well as that, a condition called Zolliger-Ellison syndrome or gastronoma, a very niche condition. I won't go into too much detail for that. You just need to know that that there's a risk factor, as well as that, obviously, any kind of drug use, family history. Some study also showed that blood groups also might be a risk factor, and then alcohol. So, peptic ulcer disease, 90% of the time it will be duodenal ulcers, and the most likely cause is H. pylori. Okay, and it's, like I said, it's more common than gastric ulcers, and when the most significant differential factor in your history wise is that it is relieved by eating, in comparison to gastric ulcer where it's actually worsened by eating. So this is quite a good thing to remember for exams. So if the history is that the patient had some sort of pain before dinner and it's relieved, then relieved after eating, then you would consider duodenal ulcer, and then if it's worsened by eating, you would consider gastric ulcer. So in terms of complications, like I said, peptic ulcer disease, you can lead to hemorrhage, and then as well as that, you can form sort of edema and sclerosis, which can then lead to further obstruction or infections in the GI tract. And obviously, when the wall gets too weak due to the thinning of from the ulcer, then you can potentially get peritonitis or perforation. You would consider doing a urea breath test or a stool antigen test as a first line. Following that, you obviously would do some sort of biopsy through endoscopy or through endoscopy alone. However, if it is H. pylori negative upon test, then you would consider using a PPI only until the ulcer is healed. However, it is positive, then you would consider something called the eradication therapy. Here's just some more facts about H. pylori. So it is presenting 95% of duodenal ulcers as well as 75% of gastric ulcers. It is also associated with gastric malignancies, and it can cause something called a multoma or a B-cell lymphoma of the MALT tissue. And by eradicating it, it's actually a really good treatment for that form of tumor. And then you can get also something called atrophic gastritis. So in terms of management wise, like I said, if it is negative, then you would consider using a PPI only. However, it is positive, you want to use eradication therapy, which can mostly be achieved within a 7-day course. So this is a combination of protopump inhibitor
and amoxicillin and clarithromycin.
As well as that, if they are, say, penicillin allergic, you can consider metronidazole or clarithromycin instead of amoxicillin and clarithromycin. So now going on to GORD, it is one of the most common differentials of chest pain. However, in order to diagnose that, you want to rule out any other serious cause, such as MI, dissection, PE, etc. As well as that, it is defined as symptoms of esophagitis secondary to the refluxed gastric contents. So in terms of the management wise, you want to send them for endoscopy ideally. That's the gold standard. However, obviously you want to try giving them drugs first, such as a PPI. However, in elderly patients, send them for endoscopy ASAP to rule out anything sinister. So if it is proven that they have GORD by endoscopy, then they need to have PPI for 1 to 2 months. And you would consider starting on low dose if they are responsive. However, you want to double the dose if they're non-responsive for 1 month. However, if they're endoscopic negative, you want to use a full dose of PPI for 1 month only, and then low dose if they're responsive. However, if they have no kind of response to that, then you would consider a H2 receptor antagonist or prokinetic for 1 month. I'll go into these drugs later on in the drugs of the GI tract section. So in terms of complications, here's a list, which includes esophagitis, ulcers, anemia, benign strictures, Barrett's esophagus, which then ultimately can lead to esophageal cancer. Okay. These, I believe, will also be covered in later lectures, so I won't go into too much detail here. So in terms of the drug of GI tract, there's a few conditions really that the drugs are usually mostly for, so including inflammatory bowel disease, reflux, peptic ulcer disease, antiemetics, as well as laxatives. So firstly, 5-amino salicylic acid. Here's a list. Includes sulfasalazine, mesalazine, oxalazine, balsalazine. I mean, they all have very similar route of action or mechanism of action. However, they have very similar structure to aspirin. Therefore, if the patient is allergic to aspirin, they should probably avoid them, and as they could also be allergic to them. However, studies have shown that 5-ASA drugs do not damage the gut, and probably has a different mechanism of action to aspirin. In terms of the different drugs or different names, they all pretty much seem to have different bonds or some sort of special coating. However, you don't really need to know this in much detail, as they largely all have the same mechanism of action. So in terms of dosing, for sulfasalazine especially, is 2 to 4.8 grams daily, and indications includes mild to moderate active UC, as well as you can also use it for maintenance of UC. This is by reducing the inflammation, and that also decreases the risk of colorectal cancer. Side effects includes nausea, vomiting, as well as other types of GI upsets, as well as that. It's very rare, but it can actually worsen the colitis. And the following is more specific to sulfasalazine due to the sulfonamide's presence, which includes bone marrow suppression, hemolytic anemia, hepatitis, as well as male infertility. Here's a list of 3 examples of steroids. So you've got prednisolone, hydrocortisone, or budesonide. And then brief drug profile. Its indication includes the induction of remission in ulcerative colitis as well as Crohn's. However, it has no role in maintenance whatsoever. So main maintenance therapy is your 5-ASAs. As well as that, obviously, it immunosuppresses to decrease the amount of inflammation, especially in acute active phase. As well as that, the main action it has is to reduce the L1s, TNF alphas, and interleukin 8, which all in all prevents inflammation and leukocyte migration. So here's just a brief review of obviously the side effects of steroids, which again will be tested in both rheumatology as well as GI as well as endocrine. So in terms of routes of administration, it can be taken orally via IV, enemas or suppositories. So here's a brief list of side effects. You should try to learn them, and they like to ask about side effects of steroids a lot. They can easily list 5 of them and then ask you to identify the one that's most likely or the one that doesn't occur in steroid use. Now moving on to anti-secretory therapy, we'll talk specifically about PPIs and H2RA or histamine receptor 2 antagonist. So PPIs includes omeprazole, lansoprazole, pantoprazole, rabeprazole, esomeprazole, etc., as well as the antihistamine receptor includes ranitidine, cimetidine, etc. So the main purpose for both of these is to decrease the amount of acid production. So omeprazole here inhibits the proton pump itself, and then the antihistamine works on a slightly different pathway as shown here. So in terms of the anti-secretory therapy itself, it's indicated, like I said, in PUD, in H. pylori, as well as GORD, as well as in patients who are on NSAIDs, and last of all, in patients who have Zolliger-Ellison syndrome. So in terms of the other side effect it have, obviously with any GI drugs, there's chance of diarrhea, GI upsets, as we are disrupting the equilibrium in the guts by stopping the acid production, etc. As well as that, some studies have shown that it also produces headaches, and it can also increase the risk of C. diff. As it is a weak cytochrome P450 inhibitor, obviously you need to be careful if you're taking other drugs that are also carried by cytochrome P50, such as phenytoin, warfarin, or theophylline. Here I've listed all the antiemetics, well, the main ones that you need to know about, which includes cyclizine, metoclopramide, and ondansetron. So as you can see, all of them act on the chemotactic trigger zone. As well as that, you just need to know the basic, the class they are in, as well as their main side effects. So I'm not going to read it out. So learn this in your own time, and hopefully this will get you some marks in the exam. And again, here's the laxatives. Again, I won't read it out. You just need to know the common ones, how they affect, as well as a brief mechanism for action, and as well as their side effects. Learn them, they're all very self-explanatory. So that's pretty much it. So we had a brief discussion about gastric bleeding in terms of how it presents, how we would manage it, and what kind of resuscitation we would consider. As well as this, we had a brief discussion of endoscopy therapy and its stratification. And then we also had a brief talk about GI drugs. We talked about reflux disease as well as peptic ulcer disease. Thank you for listening. Please remember to subscribe and give feedback at the end of this. And then in order to get the slides, you just have to finish the feedback, and then you'll get the slides at the end. Thank you very much for listening again.